Camara Phyllis Jones is a senior fellow at the Satcher Health Leadership Institute and Cardiovascular Research Institute, and an Adjunct Associate Professor in Community Health and Preventive Medicine at the Morehouse School of Medicine. Previously, Dr. Jones was the Research Director on Social Determinants of Health and Equity at the Centers for Disease Control and Prevention, and an Assistant Professor at the Harvard School of Public Health. Dr. Jones received her bachelor's from Wellesley College in Massachusetts, her MD from the Stanford University School of Medicine, and her MPH and PhD from the Johns Hopkins School of Hygiene and Public Health. It's no wonder she can only get to Oregon once every 8 years or so. Dr. Jones is a family physician and epidemiologist whose work focuses on the impacts of racism on the health and well-being of the nation. She seeks to broaden the national health debate to include not only universal access to high-quality health care, but also attention to the social determinants of health, including poverty, and the social determinants of equity, including the impact of racism. As a methodologist, she has developed new methods for comparing data in order to investigate population health level risk factors and propose population level interventions. As a social epidemiologist, her work on race-associated differences in health outcomes goes beyond documenting those differences to vigorously investigating the structural causes of those differences. As a teacher, her allegories on race and racism illuminate the topics that are otherwise difficult for many Americans to understand or even discuss. She hopes through her work to initiate a national conversation on racism that will eventually lead to a national campaign against racism. On a personal note, you will not have had enough of her by the time the day ends today. I can guarantee that. But the good news is she's on YouTube. You can take one of your devices after today, and I have watched your TEDx Emory talk 3 times now. And the way that you use allegories and just your presence on that stage to tell that story has actually really helped me convene a better conversation with my circle. So thank you for that. Please join me in welcoming Dr. Camara Jones to the stage.
Good morning, everyone. I am delighted to be back here in Oregon and in Portland in particular, and I'm delighted to be in this room with all of these people who are coming from very different vantage points to talk about the social determinants of equity. I actually, to my mind anyway, was among the early ones making a distinction between the social determinants of health and the social determinants of equity. So we're going to have a conversation this morning. I'm going to present some frameworks, some of my teaching stories, my allegories, some guideposts, even a treaty. I'm going to share with you a lot of different tools that will help us in understanding why addressing systems of structured inequity, and in particular racism, which is foundational in our nation's history, and continues to have profound impacts on the health and well-being of the nation, yet many people are in denial of its continued existence. So I'm going to give you tools for all of that. But it is going to be a conversation. I'm not going to stand up here and talk at you, and you're like, okay, at any point, if you have something to challenge me on, like Dr. Jones, that might be all well and good in Atlanta, Georgia, but here we are in Oregon. What do you mean, right? So I can hear some of that. If you want to say, oh, Dr. Jones, you are living my life, amen, or anything in between, at any point, please feel free. So because this is being taped, I'm going to ask you to go to a mic. So what you should do is wave your hand wildly and then walk to one of the 2 mics that are on the sides in the middle, and then I will interrupt. I'll finish my sentence, and then we'll go to your contribution. There will also be times where I might stop and say, does anybody have anything to add to the story I just told? So I earnestly want this to be a conversation. The lights are in my eyes, so if you want to get my attention, you're going to have to do like that, okay? But Let's go. So, the first offering I have is actually what I call my cliff analogy. It's a cartoon animation to let people who are interested in health understand that there are many different levels of health intervention, all of which we must take into account, and which helps us understand why addressing racism and other systems of structured inequity, why that's a core function of the health enterprise. So here we go. Oops! Boom! Somebody just fell off of the cliff of good health. And if that were you or somebody in your family, you would be delighted to find an ambulance at the bottom of the cliff to speed you on to care. But if we were concerned about other people who might come along that cliff face, so if we were concerned about community health or population health or public health, we might well ask ourselves, what could we put in place as a health intervention besides just stationing lots of ambulances at the bottom of the cliff? So somebody in the room is going to say, I know, let's put a net halfway down. That way, even if people fall, we can catch them before they get crunched up at the bottom. So that's a great idea. Although the more you think about it, nets do have holes in them, so some people might fall through the cracks. But never mind that, we could actually try to make that a trampoline halfway down. No holes in a trampoline. But even if we had a trampoline halfway down that cliff, we might well find ourselves with lots of people just bouncing up and down at half functionality, not able to get back to the top of the cliff. So what else could we put in place as a health intervention? Well, clearly we need to be thinking about a fence at the edge of the cliff to keep people from falling in the first place. But even that fence has to be a very, very strong fence if there's a lot of population pressure against it. So what else could we do as a health intervention? Well, we could move the population away from the edge of the cliff. So let me label the interventions that I've depicted so far, where the ambulance at the bottom of the cliff represents acute medical care and tertiary prevention. So on the public health side of things, we talk about 3 levels of prevention: primary, secondary, and tertiary, where tertiary prevention is preventing complications from disease that's already manifest. So that's preventing amputations from diabetes or the like. So that's your ambulance. The net or trampoline, halfway down, these are our safety net programs, which are often in our social services, as well as secondary prevention, which is early detection, screening programs, which can be in community settings or in clinical settings. So, for example, prostate cancer screening or breast cancer screening and the like. The fence at the edge of the cliff represents primary prevention. So that's preventing bad things from happening in the first place. So in a clinical space, a huge, quick example of that is immunizations. But it could be a policy, like a tobacco 21 policy to prevent easy access of young people to tobacco products. So you could think a lot, of those things. Moving the population away from the edge of the cliff is what people are describing now as addressing the social determinants of health, or these social forces, the social determinants of health. And if you haven't been steeped in that, my quick definition of social determinants of health are those determinants of health and illness that are outside of the individual. So they're beyond our individual genes, and they're also beyond our individual behaviors. They are, in fact, the contexts of our lives, right, that create behaviors and make some behaviors have risk or not. So that can include individual contexts, so our individual education or income or wealth. So addressing poverty is a huge way of moving the population away from the edge of the cliff. They can also include, these contexts can include neighborhood context. So they can include the quality of housing in your neighborhood, or whether you're near environmental hazards, or are there jobs in your neighborhood? And even if there isn't a job, there is your transportation to a job. Is it easy to get, well, here I am in Oregon, so I mean, when I'm talking in Atlanta, a real question is it easy to get fresh fruits and vegetables where you live? Or do you instead live in a food desert, or what some people describe as fast food swamps? I don't know the different parts of Portland or Eugene or the rest of the state, so I don't know. I know that in rural and wilderness areas, transportation even to healthcare is a problem. So all of these neighborhood contexts, addressing adverse neighborhood conditions, would be a way of moving the population away from the edge of the cliff. So if we wanted to take an example like infant mortality and say, well, what would these different levels be if I'm trying to address infant mortality? Well, the ambulance might be neonatal intensive care units. The net might be prenatal care, screening pregnant women for problems before they become big problems. The fence might be excellent maternal nutrition, maybe even our women, infants, and children's programs. Or, pregnancy circles or the like. Moving the population away from the edge of the cliff could start with having excellent educational opportunities so that young girls didn't have babies so soon. So, you could take lots of outcomes, you can put them along the cliff and think about, is the work that I'm doing, where is that along the cliff? But as useful as this diagram is, even for starting community conversations or starting conversations with lawmakers, it has a huge fatal flaw. This cliff right now does not yet equip us to talk about how health disparities arise. So I want you to keep this cliff in the back of your mind for just a second. I'm going to shift gears to talk about how health disparities arise on 3 levels, and then we'll come back to the cliff. So how do health disparities arise? Well, first of all, there are many axes on which health disparities arise. A huge one nationally is race, ethnicity. That's anytime you drill down anywhere in this country, I'm going to tell you, unfortunately, because of structural stuff, they have structural racism and all. Even here, if you start drilling down, you will most likely find racial ethnic differences even in the same neighborhood, right? But there are also regional differences, social class differences. So there are many axes along which disparities arise. Especially for the racial ethnic disparities, we have lots of evidence about differences in the quality of care received within the healthcare system, even if people are in the same system. So in 2002, the Institute of Medicine released its unequal treatment report, which pulled together what were then hundreds of studies. If we were to do the same thing now, it would be thousands of studies documenting that even for people in the same health system or covered by everybody in the VA or everybody covered by Medicare or Medicaid, there might be differences in how vigorously your chest pain would be investigated or treated, depending on your race, or differences in how much pain medication you might get if you walked into an emergency department with a long bone fracture, depending on your ethnicity or your race. But that IOM panel that documented those differences and actually sent a shockwave through the communities of health care providers who were like, oh, I try to treat all my patients the same. Well, it shows the importance of actually looking. Yeah, we can try all we want, but actually looking and seeing, shining that bright light of inquiry, what's really happening. It should have sent a shockwave throughout our communities of physicians and other healthcare providers. But even that panel recognized that's not the end-all and be-all explanation of how health disparities arise, even racial ethnic health disparities, because some people can't even access healthcare in the first place. So differential access is a second level at which health disparities arise. But then I'm hoping that everybody in this room recognizes that health is not created within the health sector. So a third huge level at which health disparities arise are differences in the conditions of our lives. Differences in our life opportunities, exposures, stresses that are making some individuals and communities sicker than others in the first place. And if you think about these 3 levels at which health disparities arise, differences in quality of care, differences in access to care, and differences in underlying exposures and opportunities, you could actually draw it as a pyramid, or better yet, understand it as an iceberg where the huge hidden base are the differences in the conditions of our lives. And then very often the same people who've been made sicker are frustrated because of limited access to the healthcare system. And then even those who are lucky enough to get into the system are sometimes further injured because of differences in quality of care. So now, remembering those 3 levels at which health disparities arise, we're going back to our cliff. But now we're going to recognize that we're not really dealing with a flat 2-dimensional cliff, but actually we're dealing with a 3-dimensional cliff. And at some parts of a cliff, there might be an ambulance there, but maybe that ambulance has a flat tire. So it's slow or goes off in the wrong direction. Or maybe there's no ambulance there at all, and maybe there's no net nor fence, and usually at those parts of the cliff, the population is being pushed closer to the edge. So now let me label these observations about the 3-dimensional cliff with how health disparities arise, where differences in quality of care are represented when the ambulance is slow, it's there, but it slower goes off in the wrong direction. Differences in access to care are no ambulance, no net, no fence. Differences in underlying exposures and opportunities are represented by the closer proximity of that greeny population to the edge. So now that we recognize that we're really dealing with a three-dimensional cliff, there's a whole new set of questions that arise. The first, of course, is how did the cliff become three-dimensional in the first place? And that's usually because of historical injustices that are perpetuated by present-day contemporary structural factors. But given that the cliff is three-dimensional, we also need to ask, why are there differences in how resources are distributed along this three-dimensional cliff? And why are there differences in who's found at different parts of the cliff? Why are the oranges back here and away and the greenies being pushed closer to the edge? And when you start asking and addressing those kinds of questions, you're now doing something that differs from addressing the social determinants of health, which I described as moving the population away from the edge of the cliff, addressing poverty, adverse neighborhood conditions, and the like. When you start trying to understand and address the three-dimensionality of the cliff and the systems of power that can differentially distribute resources and populations, you're now doing what I describe as addressing the social determinants of equity or inequity, which include racism, sexism, heterosexism, economic systems like capitalism and the like. So actually with this cliff, I have distilled, if you will, three different dimensions of health intervention. You know, one dimension is a line, 2 dimensions is a flat plane, 3 dimensions is space. Well, along the line at the edge of the cliff, is where we can display all of our health services, our ambulance, net, and fence, our curative and preventive health services right there. And so actually, when you say the word health to most people, they will complete that thought for you and go immediately to thinking about health services or health care. But this is, the Affordable Care Act is there, right? Even when we get to universal access to high-quality health care, that's still going to be an edge of the cliff conversation. We need to do a lot of integration along the edge of the cliff, right? We need to be integrating between, behavioral health and physical health, between, physical health and oral health. It's almost like we cut off our at the head, and if it's, with your mind or your teeth, then it goes someplace else. So there's a lot of integration that still needs to be done there. There is a lot of work trying to get universal access to high-quality health care. We need to do that because we need to join the rest of the world, the rest of almost all of the world. We need to do that because that's how a civilized society values all of its people equally. But even when we get there, that's still going to be an edge-of-the-cliff type of intervention. And we can overwhelm any system if everybody's pushed up against it. So we must move into that second dimension, which I can display in a flat plane. We must be talking about and acting about moving the population away from the edge of the cliff, addressing the social determinants of health, including poverty, adverse neighborhood conditions, and the like, if we want to have large and sustained improvements in health outcomes. But the trick there is if we're about moving the population away from the edge of the cliff without recognizing that we're really dealing with a three-dimensional cliff, we are at risk of moving some of the population, but not all of the population, and actually making health disparities worse. So we must acknowledge and address the three-dimensionality of the cliff, and we need to address these social determinants of equity or inequity, including racism, sexism, heterosexism, capitalism, and the like, if we want to achieve social justice and eliminate health disparities. I want to say a few things about this and actually share with you three questions that have come up when I've shared this animation in the past, and then invite you to let's talk about this a little bit. The first thing I want to say is that it is important for us to have people working at all levels in terms of this schema, but it's a matter of emphasis, right? And wherever you're working, if you are trying to be the best ambulance driver you can be, trying to scoop people up off the bottom of the cliff and speed them onto care, you still need to wonder, is there a net above me, and how strong is that net? Is there a fence at the edge of the cliff, and how strong is that fence? How close is the population to the edge? At what part of the cliff am I operating, and do I even act differently and operate differently when I'm at different parts of the cliff, right? So we need to have some of all of it, right? When you talk about the edge of the cliff, I talked about integration. When you talk about moving the population away from the edge of the cliff, you have clearly now gone beyond the health sector, and it requires collaboration between sectors: housing, justice, education, immigration, agriculture, transportation, all of these things to address the social determinants of health. And then when you start talking about acknowledging and addressing the three-dimensionality of the cliff, that involves inclusion in decision-making, because the mechanisms of those social determinants of equity or inequity, these mechanisms are in our structures, policies, practices, norms, and values, which are elements of decision-making. Structures are the who, what, when, and where of decision-making. Who's at the table, who's not, what's on the agenda, what's not. Policies are the written how of decision-making. Practices and norms are the unwritten how of decision-making, and values are the why. So when you start talking about acknowledging and addressing the three-dimensionality of the cliff, that is about inclusion in decision-making. Now, one question that I've often been asked, and various, it comes out different ways, but if this is a reasonable depiction of necessary levels of health intervention, and if we think that an ounce of prevention is worth a pound of cure, why are we spending so much money on ambulances at the bottom of the cliff? I have two levels of answers, and people often in conversations with groups, people add a lot more. My first level of answer is there is a lot of money being made down there on ambulances at the bottom of the cliff by health systems, healthcare providers, pharmaceutical companies, medical device companies, lots of money being made there. But it's a true and slightly cynical answer, but it's very glib. I think a deeper answer is that we are so narrowly focused on the individual in this country that we don't even recognize that there's been a health issue until somebody's fallen off of the edge of the cliff. We do not recognize the closer proximity of that greenie population to the edge as a health problem, right? We don't use aggregate measures of health and well-being that we measure. Right now we measure a few of them, like income inequality or social cohesion or social networking. We don't even really use those, right? So that is one of three huge barriers to achieving health equity that I've distilled in my mind, our narrow focus on the individual. And it's manifest in how we're spending so much money there. Here's another question. Why are the greenies launching themselves over the edge of the cliff? Now, you hear that when people say, well, why are they eating so much fried chicken? Or why aren't they reading to their children? Or why are they this? Or why aren't they that? It's the whole behavioral thing. So that also reflects our narrow focus on the individual, because when we're so narrowly focused on the individual, that narrow focus makes systems and structures that are pushing the green population to the edge either invisible or irrelevant, right? But that question also reflects a second of our three huge barriers to achieving health equity, which is that we as a nation are ahistorical. We act as if the present were disconnected from the past, and as if the current distribution of advantage and disadvantage were just a happenstance, right? And so we do not understand the history of the distributions of populations and the differential either putting in or taking away of resources along that cliff. Here's a third question that people don't say out loud, but most of us act this every day. And that is, this situation looks fine to me. What's the problem with a three-dimensional cliff? And the way that we act this out is when we might leave a beautiful home in a very lovely neighborhood, drive through a distressed area, get to a safe job in a safe place, and not feel a strong sense of urgency to do something about that disinvested, oppressed, distressed neighborhood that we just drove through, right? And this complacence, I will say, is in part linked to a third huge barrier to achieving health equity. The first was our narrow focus on the individual. The second is that we as a nation are ahistorical. The third is our endorsement of the myth of meritocracy. The story that goes something like this: if you work hard, you'll make it. Horatio Alger, pull yourself up by your bootstraps. Many different versions of this myth in our nation. And I call it a myth not because I do recognize that most people who have made it have worked hard, although we also need to admit that not everybody who's made it has worked hard, right? Anyway, but beyond that, even as we recognize that most people who have made it have worked hard, there are many, many, many other people working just as hard or harder who will never make it because of an uneven playing field that has been structured by racism, sexism, heterosexism, regionalism, and all, that been structured and are being maintained, that uneven playing field. And when we do not acknowledge the unevenness of the playing field by naming out these systems of structured inequity, these social determinants of equity or inequity, then we are complacent with that myth of meritocracy. So that when we look at the cliff, we say, well, if those greenies just tried harder, if they just took a step back, they would be okay, without even understanding that it might be more slippery at that edge, closer to the edge where the greenies are. It might take even more effort for them to step back than an orangey further back. We say, well, if they really worked hard, they could get an ambulance or a net fence without even understanding what took those things away or, what happened there. So that's the ahistorical thing. But in other words, if we say if they just worked harder, they would have the stuff they need. So I don't have to care about this. It's on them. That victim blaming, that is that myth of meritocracy in action. So is there anybody who would like to add something? In fact, I'd like to hear from at least one or two people so I can sort of know where we are as a group. Where are the mics again? I can't even see them. Okay, there's one over there. And is there somebody standing? Is somebody standing at that one too? No, okay. Yes.
Okay. Hi, thank you so much for this analogy. I was interested to hear, what do we do when we have oranges who are picked up and taken to where the greenies are due to institutional racism, systemic racism? Do we have any language for people who have health protective services, but because of systems within our society that take them out of their path and with these protections and put them on the line of the green path?
That's interesting. Can you make it even more real for me, like in an example?
I mean, an example I can think of within Portland is with ICE and with racism against Hispanic individuals. A lot of fear. I think, personally, if people are taken from the orange to green, it usually has to do with fear or some institutional idea. But with something like that, there may be people who have health protective services, are okay, or have immigrated to try to find a better path, and then because of barriers, they're then on the green path.
Right. So it's an interesting question because in the question is inherent that there's an orange path and a green path. And I know you're not meaning it like this, but as I hear the question, I mean, so actually, they're like little people paths, but
right, and it's a blurred line. I'm just
well. So the fact that we can even identify an orange path and a green path is because of structural stuff that's happened, right? And so actually, where the oranges are is just as legitimate a place for the greenies to be. So I'm not getting your question yet. I'm just reacting to how we often, I'm going to tell a story later about a gardener's tale with pink and red flowers, and people often talk about the pink soil and the red soil, and it's not that. It's the soil in which the pink flowers find themselves and the soil in which the red flowers find themselves. That won't make sense to many of you right now. But anyway, so you're saying, though, for people who have come from in their places or whatever from relative advantage are being pushed to disadvantage.
Yes.
And what to do about that.
Right, or basically right now the way we've seen this three-dimensional images is that there's two paths, and I guess my question or comment is, what about all the paths in between and being able to go between the two based on your situation?
So I guess my answer is there are not two paths.
Yeah.
I think that's my answer. There is treatment, there is sorting. There's a system of sorting and structuring opportunity and assigning value. And so the sorting machine is working it out that those that are not as valued are going to be pushed closer to the edge, and those that are more valued are going to be pulled back and given resources and all that. So So what we need to do is something about the sorting machine. And so for those intermediate people, the sorting machine maybe hasn't figured out what they want to do with them yet. Or so, am I getting it all? I'm reacting to something in how the question is phrased because I don't think that, I want you to get back at me one more time, but I just don't think that, I'm going to add something else, and then that might help us come together to an understanding. So first of all, the orangies back there may not be looking far enough around to even understand that the greenies are being pushed closer to the edge. Mm-hmm. Okay, so the orangies, and in fact, most of us do not even compare ourselves. Even that orangey that's closer to me isn't even looking at the other orangey that's nearer the edge, because we don't compare ourselves to people who have less than we have. We most often compare ourselves to people who have more. Mm-hmm. Right? And because we're all in our bubbles, those orangies may not even know that just across the cliff there are people who are just as kind, funny, generous, hardworking, smart as they are, who are living in very different circumstances, who are being pushed closer to the edge. So the orangies may not even be aware of the greenies. So now when somebody comes into this situation, which has been this machine that's been differentially sorting and structuring opportunity and assigning value, and then first of all, they didn't know about the machine, and then all of a sudden they're in the machine, and now they're trying to figure out, what's the machine going to do with me? And maybe it's been in the middle, or maybe it's been pushing them. Maybe these reddies are being pushed with the greenies, and they're like, oh, no, but I belong over there with the oranges, but the machine doesn't care, right? Because all of us, the greenies, the oranges, all belong in the better place on the cliff, right? There's no green place on the cliff or orange place on the cliff. There's just good places and bad places, but the machine is making us think that there's an orange path and a green path. I guess that's what I'm ready. So now, having said that, I want you to ask me the question one more time, because I know I didn't get it.
But I did actually answer a lot, because I think the idea I was getting at is that it's not just one green path and one orange path, and that there's different places on it. And I think the other point you addressed was with the sorting machine, because we brought up examples like food security, education, and maybe systemic racism that we may not see. But a lot of it we can see, and we do have these systems right in front of us, sorting people right in front of us, and that is something we still need to address. It's not abstract inequity. It's very clear also.
Thank you so much. Thank you for this was a good exercise for me, and I know that, and I hope you don't feel like I put some words or thoughts or anything on you that you didn't have.
Oh,
so,
no,
yes.
Great.
Thank you very much for that question. Anybody else brave enough now?
Yeah.
No, really, I'd like to hear from at least one other person, because it won't be that long or that deep.
I'm ready.
Where I can't see.
Oh, you can't see.
Okay.
Over here.
Yes, okay.
My name is Tom Sinsick. I'm a nurse. I'm the president of Healthcare for All Oregon. So we're calling for action, right? This is a day of action. Please go to hcao.org and get involved in the movement for universal health care. Now I'll ask my question, which is, in this world, we're going to need all of these things regardless of how much we improve things. People are going to need ambulance services, primary prevention, and we need these to address these social determinants of inequity and of equity, I guess. But what we get is, well, how are we going to pay for it all? The idea of we live in an idea of scarcity, right? We can't both do this and do that. And could you address that issue? This issue of we can't both take care of people with the right kind of ambulance services and do good education at the same time.
Right. So I think that understanding that, and understanding, first of all, that we have to prioritize, and if you think that moving up cliff is going to be more efficient, then that would argue, all of that would argue for interventions that are up cliff. But we do need ambulances, nets, fences. We need to move the population away from the edge of the cliff, and we have to address the three-dimensionality. So I would say, first of all, we have to get outside of a zero-sum game idea, right, of things. I mean, that's one of the things that constrains us always. That's one of the things that makes people afraid to address a problem in that community, because then it necessarily is going to take something away from me. So we have to get out of that framing. But also, so I think that an ounce of prevention really is worth a pound of cure. I do think we need all of this. We need to have conversations about it. We also, wherever we're working or wherever we're investing as our day job, need to recognize that as a citizen, we need to be concerned about the whole. So concern about the whole is actually acknowledging and addressing the three-dimensionality of the cliff. In reality, the urgency of addressing somebody who's fallen off the edge of the cliff sometimes takes over from the importance or effectiveness of building stronger fences, moving the population, and addressing something about the three-dimensionality of the cliff. So we react to urgent problems and do all of our investment there without understanding that if we were to change our investment, that we wouldn't have as much. But part of the problem, too, is the problem of public health. How do you measure how many lives you saved with that Tobacco 21 policy? You know, how do you measure those things so when you put in an effective intervention, you can do historical measurements, but often it's difficult, but you can measure how many people you treated in the coronary care unit, right? So that measurement piece also hamstrings us. We need to be thinking about investing in opportunities and in maintaining opportunity as opposed to having to count numbers of outcomes as a basis for continued investment. So I actually am thinking, I'm going to share, this is continued thinking for me, but I have a slide toward the end where I say that understanding the difference between, understanding that equity is assurance of the conditions for optimal health for all people, that it's a process, and the understanding that a change in something right now will not necessarily manifest until 20 years from now in a generation when the new people come up in that system. We need to start making our investments in opportunities, start measuring changes in opportunities, and wait for 20 years for a generation to see changes in outcomes. But we're so outcome-focused, evidence-based, whatever. Prevention is hard to do the evidence-based thing, and especially if you're really about changing opportunity structures, moving people away from the cliff and all, that's really hard to demonstrate. So maybe we need to move away from that outcome thing.
Yeah. I'd like to add just the idea, when you talk about 20-year, in my 20 years working in a school health center, I saw the movement with the, talking upstream, which is soda, the poisoning of our society through soda, and the numbers of teenagers with diabetes and pre-diabetes, where 20 years before, I was never having to bother to test, and suddenly I'm having to test everybody for their blood sugars and their cholesterol levels. So that was the 20-year process I saw. So I understand about the 20 years.
Thank you so much for your question. Anybody else? Yes.
Hi, my name is Karen Stevenson, and in regards to this question of money, that last question brought the assumption that there's only a fixed amount of money available, and that if we're doing the ambulance, we have to take away from moving people from the edge of the cliff. So my question is, how can we change society's viewpoints? Because in this country, we're magically finding money to take children away from their parents, for instance. So how do we change the view that this is not a finite, tiny pot?
Right. So, I talked about 3 barriers to achieving health equity. I've actually added 2 more, but I haven't put them on the slides yet. But one of them is this notion of the zero-sum game. And that really hamstrings us, so thank you for bringing that up. The second is that, the fifth one is that we not only are we ahistorical, we don't look to the future. We're not future-oriented. So how do we get out of that zero-sum game? I don't know. We just have to decide. So policymakers, so people do find money magically, or they hawk the generations coming, with our trillions of dollars of, debt now, adding to the national debt for crazy things, giving rich people more money. So we just have to push the agenda and then see how it shakes out. But if something is important for a society, then the society will pay for it. Yes.
Hi, Doctor.
Is there somebody? Should we alternate?
Oh, go ahead.
Yes.
So far you haven't mentioned the 98% of society that sustains visible and non-visible disabilities. And
not yet. I will.
Oh, okay, because like we're the majority and we just, everybody, like I was at a disability conference and somebody came in and talked about race. My brother-in-law is African. I'm tired of hearing about race. It's not the only thing there is.
Absolutely. I agree with you. What I heard you say is that you haven't heard me talk about the disability community, right? And I said, not yet. I haven't even talked. What I just did was frame 3 levels of health intervention. I'm going to share another quick story, and then I'm going to define racism. Then I'm going to generalize that definition of racism to be a definition of any system of structured inequity. So then we'll talk about the disability community and the like, and point out that there are parallels in all of these systems of structured inequity. So I absolutely recognize, in fact, one of my papers in 2014 was talking about parallels, intersections, and braiding the strands between the struggles in the disability community and the struggle around racial ethnic health disparities. So I very much appreciate the point that you're bringing. And we just, bogged down right now here in terms of I've talked too much. And anyway, but we'll get to that. But the other thing is, I'm sorry that you say that you're tired of hearing about race ethnicity. And the reason that makes me a little sad, I mean, you're entitled to be tired or not tired, right? But is that, I think I already said it once today, that racism is foundational in our nation's history and continues to have profound impacts on the health and well-being of the whole society, and yet many of us, in denial of its continued existence or its primacy or its importance. And so, recognizing the parallels between different systems of structured inequity, I still think that if we want to make any movement at all in this country, we must be at least anti-racist, even as we're picking up on the other struggles. And that's not to put anybody down. That's just where I'm coming from. Okay. Here, go back to the mic, please. Go back to the mic so we can all hear.
They're ramming, quote, white privilege down everybody's throat. And I have privilege now because I have good housing where I'm getting help. But, 28 years of job discrimination because they keep the blind unemployment rate 97% in Oregon. I don't feel like that's white privilege.
Say it again, because your mic, get right to your mic, because I'm not even getting all of it.
They don't get it. Everything is, the people that talk about race think it's the only problem around, and it isn't.
Okay, so...
there are other problems that has to be dealt with, but,
yes.
It's not like that's the only thing and no other problem exists.
So I think that... I think that people who talk about issues of race and racism do not think that's the only problem around, but they think it's a major, huge problem in the society where there's a blind spot. You're saying you think there are blind spots around other things. I just want to say on the issue of white privilege, which I haven't said the words yet, but I'm about to. But if you are living as white in this country, you do have white skin privilege right now in this day and time. You can't deny it, you can't shed it, and it's not protecting you from poverty, it's not protecting you from disability, it's not protecting you from other things, but you do have white skin privilege, and so you get the benefit of the doubt in terms of, things, and that you have the historical context in which you live now, which often we don't understand history, so we don't understand historical advantages and the like. So, even for people, I'm going to just give you 2 things to say about that. So do you remember in McKinney, Texas, now it's almost 3 years ago, there was a big story about how there were these young teens who were celebrating one of their friend group's 13th birthday at a pool in one of their neighborhoods. And so they went to the pool, and some of the people who were there at the pool objected to their being there and called the police. And what we saw was a police officer dragging this young black girl by her hair and then sitting on her. And we saw young black boys sitting on the edge of the curb with their hands handcuffed behind their backs. And I might ask you, how do we know about this thing that happened? And most of you will say, oh, social media. But I mean, like, let's go deeper. How do we really know? I didn't know until the next day when I was listening to an interview of a young white boy who was part of the friend group who said, it's almost as if I were invisible to the police. He was part of the friend group. He was at the party. He saw what was happening to his friends. He could have run away to protect himself. But instead, he recognized his white skin privilege, which made him almost invisible to the police. And he stood there and documented what was happening to his friends. If you are living as white in this country right now, you have white skin privilege. You can't shed it. You can try to deny it, but it is operating for you today. And so the challenge is not to try to deny it or get offended, but to use it. To use it. Poor people, poor white people, at the same level of income as poor black people, and there's some poor white people, matched for income, tend to live in more mixed income settings, whereas poor black people, same level, live in concentrated poverty. I was once, when I worked at CDC, we were doing a project addressing poor black and white women in North Carolina. And the CDC was going to march out and do some kind of little show and tell, and I couldn't go. So I gave my friend 5 slides on racism. I said, can you please share these during our little show and tell? And she said, Camara, why do you want me to go there talking about racism when this project, when the thing that these women have in common is that they're all poor? My response was, they have 2 things in common. They're all poor, and they all live in a racist society, but they experience that second thing differently. So again, this is the distinction, and it's hard. But the story I'm about to tell, I'm using up all my time, I know, but the story I'm about to tell hopefully will make it clear for all of us. So I had 2 people over here, and then I see 2 more over here. Okay, and then don't anybody else come back up to the mic right now. We'll have other opportunities. Okay, yes.
Thank you, Dr. Jones. I appreciate your being here. I'm a public health prevention specialist. And one thing that's embedded, and I know you're going to talk about this, but I wanted to call it out, is the issue of power. Who owns power in terms of redirecting resources? It's interesting to me, and you've already talked a little bit about it, but I'd like to hear more. It's interesting whenever I talk to legislators about funding community health, preventive medicine, prevention in general. Our health departments are totally underfunded here in Oregon. They talk about other priorities and the healthcare system. You've called that out, but how do we shift power, especially in the communities? And I'd love to hear you thinking about that.
Thank you. Well, we can do better is one example of how you shift power, convenings and organizing. So when people recognize that it's not what can I do, but what can we do about this situation, that is the first thing. So it's agenda setting and then organizing. Thank you. I'm going to have very quick answers. So next here, and then
good morning.
Good morning.
I'm Shafia Monroe, and I want to know that Dr. Drew Crawford told me to tell you good morning. But I want to just talk about tertiary care and the increase nationally of women of color, particularly black women, dying in the postpartum period, where they're often going to emergency for their complaints and being set apart. So the ambulance is here to catch it, and that could mean emergency rooms as well. What can we do, or your suggestions around that?
I think that what it reflects is differential valuation of those patients in those times, in those acute settings, not taking the complaints or the symptoms that are reported from some people as seriously as from other people, or, just put it. So I think it reflects differential valuation. So what can we do? So you can put protocols in place so that everybody is mandated to provide excellent care. We can do more monitoring. And I was just at a meeting yesterday where they were talking about health disparities and blah-de-blah-de-blah. And it's almost as if we talk about health disparities in the passive voice. Like, there it goes again. We have these differential numbers of women dying in pregnancy-related deaths, as opposed to understanding the active thing. We need to monitor, well, which systems is this happening? Who's caring for them? What is it that's not being done? It's almost like you say, somebody was hit by a car. Yeah, but who is driving the car? So let's change from the passive to the active voice. So I think that for the maternal mortality, especially these things, these are very sensitive ambulance level things. I mean, you have other stuff like infant mortality that's reflecting, how close the population is to the edge of the cliff, and more life course things. But very often these maternal mortality differences are actually quality of care issues. And I think that we need to make sure that people understand that they have to pay equal attention, or maybe even more attention to some populations, that we have to value all of us equally.
Thank you.
Thank you. And there were two over here. Yes.
Thank you. I want to just briefly make a direct response to the earlier conversation we had about just the intersection of racism and oppression against folks that have disability, and just to say that I think what you're saying is all oppression is interconnected, all justice is interconnected, and we cannot deny the foundational structural racism that permeates every single system when we dig in, and that our liberation is connected and bound up in each other's, that nobody is free until everybody is free, and that we have to look at the whole, including everyone's lived experience, and honor the complexity of that historical trauma and that continuing reality of violence, so that we can move everyone, all of us, every single body, away from the edge of the cliff. Thank you.
Thank you. Oh! Thank you.
I think that was why I let her go before me, because I saw that coming. My name's Celie Diamato. I am a member of the low-income disability community. I am here to take care of myself and to help my community. Where I currently live could be the best petri dish for social determinants of health. It ranges from people dying, people not getting proper health care, not having an advocate to deal with issues that they have. My question is, as a member of the low-income disability community, what is the city of Portland going to do to help people sustain a healthy lifestyle, to be able to live in a community where management or tenants aren't attacking each other, setting double standards, making it an issue as to where if a member of a community voices their opinion that they're not harassed, retaliated against. I'm poor, I'm disabled. A lot of you people see me every day, have no idea who I am. I don't think I ask for much as me and other people in my community. All I think we need is a honest approach to dealing with each other as we are as human and not on a status level. I'll get to the question. How can you implement social determinants of health training to people so that they don't treat people such as myself less than?
Mm-hmm. So it's again, so I just had two quick thoughts, and I'm not going to wax long. The first thought is that sometimes that zero-sum thinking makes, remember when there was the whole discussion of curb cuts on curbs, right, just to accommodate wheelchairs and the like, right? And people were like against that. But now, how many people use those for their bicycles, for their strollers, for their, for so many things. So people who feel like if we make some accommodation for that group, it's going to take away from me, do not understand what was just stated before. That anything that we do that makes something easier for some human is going to actually benefit all of us. Correct. And it also is about how we don't understand that every single person on this planet has something of value to offer. Actually, correct, every single person has something to teach each one of us. Every correct one of you has something to teach me, and we to teach each other. So the way that we have gradations of value, of how we value different people, is whack. Now, you asked me the question, how do we fix that? My little way of fixing it is going to be, so you haven't actually heard any of my allegories yet, but if I do my job very quickly, and I'm looking at time, then I'm going to tell you 3 of them before I sit down.
Okay.
But is to turn my allegories into children's books, right? So that now we can start having these conversations, even if the librarian or the parent or the teacher doesn't know how to start a conversation, they can read the book with the child, or the child can read the book themselves and start conversations very young. Because I used to just think that this was a structural issue, but now I understand that there's both the structure part of it and the values, how people are valued part of it. And the values piece we haven't been addressing as much. I say it again?
I said, where we live, we aren't valued.
Right. And that's a shame. All of us are of a thank you so far. But now, if you have something you want to add, just write it down. And if we have time at the end, then I'll come back and open it up again. Okay? Good? Okay. So here's a story that if I have 5 minutes to talk about racism, this is the story I tell. This is one of the allegories that's based on something that happened to me in my own real life. So let me tell you what was going on. I was a medical student, and you know, I was very studious. So one Saturday, some friends and I were in my apartment. We were studying. We started studying long and hard, and it got late, and we got hungry, and I had no food in the apartment, which was typical. But never mind, we decided we're going to go into town and try to get something to eat. So we go into town, and we find a restaurant, and we walked in, and we sat down, and the menus were presented, and we ordered our food, and the food was served, and here we are eating. So you're like, oh, that's not a very remarkable story. Most of us have had that kind of experience. But as I sat there eating with my friends, I looked across the room and I noticed a sign. And that sign was a startling revelation to me about racism. So now I've intrigued you. Oh, Dr. Jones, what did the sign say? Well, what did the sign say? The sign said open. So now I know I've lost most of you. So let's recap. Here we are sitting in a restaurant eating. I look across the room. I see a sign that says open. If I hadn't thought anything more about it, I would have assumed that other hungry people could walk in, sit down, order their food, and eat. But because I knew something about the two-sided nature of those signs, I recognized that now, because of the hour, the restaurant was indeed closed. And that other hungry people, just a few feet away from me, but on the other side of the sign, would not be able to come in, sit down, order their food, and eat. And that's when I understood how racism structures open-closed signs in our society. That racism structures a dual reality. And for those who are sitting inside the restaurant, at the table of opportunity, eating, and they look up and they see a sign that says open, they don't even recognize that there's a two-sided sign going on, because it's difficult for any of us to recognize a system of inequity that privileges us. So it is difficult for men to recognize male privilege and sexism. It is difficult for white Americans to recognize white privilege and racism. It is difficult for temporarily able-bodied people to recognize the ableism and disabled, I don't know how you would call it, prejudice-ism. It's difficult for all Americans to recognize our American privilege in the global context, except we got a little taste of that on the health side with Ebola, did we not? Yet those on the outside are very well aware that there's a two-sided sign going on because it proclaims close to them, but they can look through the window and see people inside eating. So back inside the restaurant, to those who ask, is there really a two-sided sign? Does racism really exist? I say, I know it's hard for you to know when you only see open. In fact, that's part of your privilege, not to have to know. But once you do know, you can choose to act. So it's not a scary thing to name racism. It's actually an empowering thing. It doesn't even compel you to act, but it does equip you to act, so that if you care about those on the other side of the sign, which is an if, then you could even talk to the restaurant owner, who is, after all, inside with you, and you could say, restaurant owner, there are hungry people outside. Why don't you let them come in and eat? You'll make more money, and oh, the conversations we could have. Or maybe what you'll do is pass food through the door or try to break the glass or tear down the sign, but at least what you won't be doing is sitting back saying, wonder why those people don't just come on in and sit down and eat. Because you'll understand something about the two-sided nature of that sign. So we could have a long conversation here. I'm just going to say I once just started a community conversation once with this story. I asked the question, how could people who are born inside the restaurant know something about the two-sided nature of that sign? Because there are ways. We had a 3-hour conversation, so I'm not even going to open it up to you all right now. No. I'm going to carry on from here and say that that first cliff analogy was to say that addressing racism, sexism, ableism, all of these systems of structured inequity is inherent to the health process. The second story is to give you a sense of how these systems of structured inequity, I said racism, but all of them operate to create dual or multi-sided realities. So finally, I'm going to define racism, which is a system. So it's not an individual character flaw or a personal moral failing or even a psychiatric illness. It's a system of power. A system of doing what? It's a system of doing two things, of structuring opportunity and assigning value. On what basis is the opportunity structured, and on what basis is the value assigned? It's based on so-called race, based on the social interpretation of how one looks, which is what we call race. I sometimes go long on that, but I won't. The impacts of this system include that it unfairly disadvantages some individuals and communities. And when we think or talk about racism at all, that's where we go. But it shouldn't take us long to recognize that every unfair disadvantage has its reciprocal unfair advantage, so that racism is also unfairly advantaging other individuals and communities. And that is the whole issue of unearned white privilege that we hardly ever talk about in this country. And the reason that we hardly ever talk about it is that it makes some people, especially some white people, uncomfortable. And I imagine I may have just made some people in this room uncomfortable. And I'm not trying to make anybody uncomfortable. I'm trying to start us on a conversation. I used to say in that acknowledgement that I might have made somebody uncomfortable that I want you to just shake it off, and stay with me, because I'm going to tell you some stories that will equip you to have some good conversations. But now you know what I say? I say if you feel uncomfortable, it might be better to lean in. Because I now recognize that for all of us, the edge of our comfort is our growing edge. But however we are, we recognize now we have a system that's doing these two things. There is a third impact of racism that many of us don't recognize, and that's how racism is sapping the strength of our whole society through the waste of human resources. So lots of examples. I'll just pick on one. The fact that we are not yet vigorously investing in the full, excellent public education of all of our children because the blinders of racism have made some people feel there is no genius in the barrios, the ghettos, the reservations. We can get along very well, thank you, without those kids. But of course there is genius in all of our communities. And if we were to only fully and vigorously invest in that genius, we could be doing so much better as a nation or even as a world. We might already be up on Mars. Thank you. Thank you. Might already be up on Mars farming, if that were a good idea, if we were to invest in all that genius, right? So many examples, I won't go there. I just want to say that I think that attention to that third point about how racism saps the strength of the whole society is very necessary, especially in these days. And we need more media stories about that. Media, I think there's some media in here. We need more data collection, scientists, health workers, about that. We need more conversations around our dinner tables, everybody, about that, because we need more people filled with a sense of urgency to dismantle this system and put in its place systems in which all people can know and develop to their full potentials. I just want to say one more thing before I get off this slide. When I was at CDC, at the end, part of the reason that I left CDC, so I was at CDC for 14 and a half years. First 10 years were great. We were building all this stuff. Moved to a different part of CDC. Turns out that they were not so interested in me addressing racism. They didn't think it should be anywhere at CDC at all, but if it was, it wasn't going to be in that division. Right? So I had a particular person who had to approve my presentations who said I needed to take that second point off of my slide, the unfairly advantages other individuals and communities. And I was like, but I can't do that. This is the truth. So our compromise until I left CDC was for me to take the words unfairly off of both of those top 2 points. So I could talk about disadvantage and advantage as long as I didn't characterize any of them as unfair. Well, that interaction taught me something very important. What it taught me is that there are many people in this country who think that there is disadvantaged and normal. And the reason that people think there's disadvantaged and normal is because we are ahistorical. And people do not understand that their so-called normal is built up on a whole mountain of unfair advantage. So now, that definition I gave you of racism, finally to the very good comment from, I didn't remember your name, but over there, the comment from the disability community about what about us, that definition that I just gave you of racism can be generalized to be a definition of any system of structured inequity. So, what is sexism? That's a system of structuring opportunity and assigning value based on gender that unfairly disadvantages some, unfairly advantages others, and saps the strength of the whole society through the waste of human resources. And there are many axes of inequity operating in our society today, intersecting in communities and in individuals. And all of these are operating at least as risk markers for how opportunity is structured and value is assigned, even as a smaller group of them are also risk factors in the progression to disease. So you might ask, as you did before, why am I so much talking about race as the axis of inequity and racism as the system when I recognize that all of this stuff is going on? And I do recognize it's all going on, but here for the third time this morning, racism is foundational in our nation's history, and yet many people are in denial of its continued existence. So we must say the whole word racism, ism. We stop at race, or we might even talk about cultural competence or just, disparities or disproportionalities. All of those things are important things to talk about. But we must talk about racism in this country if we're going to do anything about it, even as we also engage in struggles around these other axes of inequity. It is not an either or.
Is that my brother-in-law is from Africa, so in our family, we're just the family. And he's even said it would be less of a problem if Americans talked about it less.
It would be less of a problem?
If we all talked about it less, like you.
But that's because how long has he been here?
Oh, since the 70s.
So I don't know, because usually it takes about 5 years for people immigrated from other parts of the world who are labeled as black. When we come here, like we're born here and we're labeled as black, right? Sometimes it takes, so I don't know why he doesn't understand what's going on. But, for Amadou Diallo, who was in 1999 shot 41 times by the police officers in front of the vestibule of his apartment building in New York because he was West African, police approached him and he was getting his wallet out to show his ID. He did not understand the context of where he lived, and they shot him 41 times at short range and killed him, of course. So it behooves all of us to recognize the differential assumptions made about people and all. We need to understand that racism exists. So I don't know why your brother-in-law is still saying that. But anyway, not talking about race or racism is not a strategy for eliminating it. We first have to name it, we have to put it on an agenda, and then we have to be intentional about dismantling these systems. It's not just a word. It's not like what Ward Connerly tried to do in California, the CRECNO. This is old now, but he had a proposition that was about classification by race, ethnicity, color, and national origin. He wanted to eliminate the ability to collect data on those axes in California because he said all this talk about race is making racism. Well, no. What it is doing is documenting the impacts of racism. If you just stop collecting data, the same stuff is still going to be going on. We just wouldn't know about it, and we couldn't prioritize it and put it on agendas. So I will tell you when we should stop talking about issues of race or racism, when no matter how you slice and dice it, there are no differential health outcomes, educational outcomes, wealth outcomes, occupational outcomes, when we no longer see these things differential by race is when we should no longer talk about race. And the reason that race is pertinent is because of racism. So we need to talk about racism as long as we're talking about race. And then when racism is no longer operating, we can let it go. Right. So here's a second of the 3 stories that I really hope to tell you. Okay. So I have I find it useful when trying to understand how racism turns into health outcomes to think about it on 3 levels: institutionalized, personally mediated, internalized. So I'm going to define those levels, give you very quickly some examples of how they operate, and then tell you another of my allegories based on my real-life experience. Institutionalized racism is the system, the constellation of structures, policies, practices, norms, and values that taken together result in differential access to the goods, services, and opportunities of society by race. This is the kind of racism that does not require an identifiable perpetrator because it has been institutionalized in our customs, norms, background, the history, all of that. It shows up as an inherited disadvantage and its reciprocal inherited advantage. We see it in terms of material conditions as well as in terms of access to power. Examples include differential access to quality housing, equal educational opportunities, equal employment opportunities, same level of income at the same level of race. Clearly those things have health impacts. Differential access to medical facilities, including linguistic access, differential access to a clean environment, and the very well-documented disproportionate placement of toxic dump sites or bus transfer stations or the like in communities of color. And then, so that's in terms of material conditions. In terms of power, it could be differential access to information, which could be health information or even information about our own histories. Differential access to power as resources. Capital resources, yes, but also social networking resources and knowing somebody on the board. Differential access to power as voice in government, media, and the like. Now, I must pick up on that top point about housing, education, employment, income. Sometimes people see me with this slide, institutionalized racism. I have that as an example, and they say, hold on, Dr. Jones, excuse me. Isn't that what we describe as social class? Why do you have that on a slide about racism? Are we talking? Oh my gosh, she's just told me 15 minutes. You thought I was talking fast? I'm going to talk really fast now. So why do you have that on the slide about racism? Are you talking about racism, or are you really talking about social class? I must answer that, because many people in this room might be feeling that question, right? The start of the answer is that it doesn't just so happen that people from marginalized, stigmatized, oppressed groups of color are overrepresented in poverty, while white people in this country are overrepresented in wealth. That is not just a happenstance. So for each marginalized, stigmatized, oppressed group, there's been some initial historical injustices. For American Indians, that initial historical injustice was the taking of the land, and then the near genocide and the moving of survivors to reserve lands, reservations, and then in some instances you found something good under a reservation, oops, you got to pick them up and move them somewhere else. I usually go through a litany of all different types of people. You know, I talk about Hispanics, Mexican people who never crossed the border crossed them, and now their grandchildren and great-grandchildren are being harassed, how we deal with labor, how we, you know, the Chinese laborers brought over here to build our railroads, unable by law to marry, unable by law to bring their families, and how we're dealing with migrant labor right now. How, you know, we had the internment of Japanese Americans during World War II, right? We did not have the concomitant internment of Italian Americans or German Americans. We were fearful, I was fearful 2 years ago that we would start interning first, you know, people who look Middle Eastern North African, or people, you know, who look Muslim or whatever. Instead, I never imagined we'd be interning children, right? Okay, for people who are of African descent, the initial historical injustice was the kidnapping of West African people and our importation across the Atlantic with tremendous loss of life in the Middle Passage. And then for the survivors and their progeny for generations, what I describe as the coerced usury of our unpaid labor for centuries to build this country. But then people hear that, and they're like, some of them are like, Dr. Jones, there you go, talking about slavery. Dr. Jones, we all recognize that slavery was an unfortunate chapter in our nation's history. But Dr. Jones, the enslaved people were emancipated by 1865, and we're now in 2019. That makes that 154 years ago. So all else being equal, Dr. Jones, don't you think the impacts of slavery would have washed out by now? But the key phrase is all else being equal. And all else has not been equal since 1865, and all else still is not equal today. And there's still what I describe as contemporary structural factors, present-day structural factors that are perpetuating each of those initial historical injustices. And these contemporary structural factors are part and parcel of institutionalized racism. So when you ask me, am I talking about racism or am I really talking about social class? My response is that institutionalized racism explains why we even see an association between social class and race in this country. And that is a hugely important aha. Now, I just want to say one more thing, two more things before I get off this slide. Some people would say, well, Dr. Jones, like the young lady was saying before, Dr. Jones, all this talk about race and racism, you know, you don't really care about poor white people, do you? And that is not the case at all. I care deeply about poor white people, poor black people, poor Hispanic Latino people, poor Asian people, poor American Indian people, poor every kind of people, right? And we need to be actively working on anti-poverty strategies. But if we had that all worked out today, and it was right here in this little remote, and this was a magic wand, and whoosh, I could eliminate poverty. In fact, I would go beyond it. I would eliminate income inequality. If I could do that right now, I would very well do that. But even if I did that, if I did it without addressing the background, structures, policies, practices, norms, and values, the mechanisms of institutionalized racism, which are deeply embedded in the fabric of our society, and were put in place to differentially shunt different populations to different possibilities. Even if I even things out today, if I eliminated, collapsed it all, in 20 years, in one generation, we would start to see a stratification by race again in terms of income. This is not an either-or proposition, anti-poverty versus anti-racism. It is a both-and. And before I leave this slide, I just want to say one more thing about how it works. Institutionalized racism can be through acts of doing, acts of commission, as well as acts of not doing, acts of omission. And very often it shows up as inaction in the face of need. The second level of racism, personally mediated racism, I define as differential assumptions about the abilities, motives, and intents of others by race, and then differential actions based on those assumptions. So this is what most people think of when they hear the word racism. Somebody did something to somebody. It includes a different idea, the prejudice, a different action. How could it impact health? Well, police brutality. So I used to hold in my head a whole litany of like 15, 20 names that I would generate, and then it got to be 30 names and 40 names, and I can't hold them. But I just want to say Charlie Landeros in Eugene, Oregon last Friday, right? Killed in front of the Cascade Middle School in Eugene, Oregon. We need to find out what's going on with that. Too many times, people of color are killed by the police. And it not only takes away the genius that was that person, and it not only fractures the family that experiences that loss, but there are whole communities who are just bracing ourselves for the next occurrence because very often there's limited accountability of police officers and police departments for those killings. I don't have on here, I have police brutality. I'm going to now add something that I call, I guess, like personal harassment in the public space, living while black, living while being a person of color, to this list, because I just want to say Jermaine Massey, here across the river, I understand, at the Doubletree Hotel, here. Okay, so anyway, so I'm not going to do a whole long thing. Physician disrespect, that could be as subtle as a physician not giving a patient the full range of treatment options because the physician figures that patient couldn't understand, couldn't comply, wouldn't act. It could be quite blatant, like sterilization abuse, which has had many iterations in our nation's history, shopkeeper vigilance, being followed around in stores, waiter indifference, not getting quick, respectful treatment, teacher devaluation, teacher looking at a young child and thinking, that child can't learn, and putting them off in the attention deficit disorder track, where that child won't even know their full potential, much less have the opportunity to develop to their full potential. Many manifestations of personally mediated racism that can impact our health. I just need to say that it can be through acts of doing as well as acts of not doing, but even more important at this level is that it can be unintentional as well as intentional. You do not have to have intended to do something racist to have had a racist impact. The third level of racism, internalized racism, I'm defining here from the point of view of members of stigmatized races as acceptance by members of stigmatized races of negative messages about our own abilities and intrinsic worth. And I will acknowledge, because some of my friends who do anti-racism training say, well, wait a minute, Camara, what about the internalized sense of entitlement that many white people are walking around with? Isn't that also internalized racism? I agree that it is. I didn't have it on this slide. I still don't, because for a long time, I didn't understand how that could turn into bad health outcomes. But maybe a sense of entitlement toward it is at the root of some of what we're just talking about as diseases of despair. But I don't have time to go deeply into that. So from the point of view of members of stigmatized races, self-devaluation, feeling maybe I'm really not as good as, maybe I shouldn't try to graduate from high school or try to attend that college or get that job or live in that neighborhood. White man's ice is colder syndrome. That's a phraseology that came from my parents' generation, and what it meant then for people of color, it still means for many of us today. So say I'm black and I need a lawyer, I might actually seek out a white lawyer over a black lawyer. Or if I'm sick, I might prefer a white doctor over a black doctor. In fact, if my lemonade were warm, I might want to go way down the street to get the white man's ice over the black man's ice, deeply believing that the white man's ice is colder, deeply internalizing the myth of white superiority. Resignation, helplessness, hopelessness turns into a lot of self-destructive health behaviors. And basically, internalized racism is members of stigmatized races accepting the limitations to our own full humanity of the box into which we've been placed. So now, very quickly, my story, my Gardner's Tale allegory. How many of you have heard the Gardner's Tale before? Wave wildly. Okay, so about a third maybe, or a fourth. Okay, so you guys listen with different ears to the nuances of the storytelling so that you can confidently tell it back. But the rest of you guys just sit back and enjoy. So I'm going to tell you first the real thing that I experienced in my life, and then I'm going to turn it into a story about racism. My husband and I had been married about a year. We moved back down to Baltimore so I could finish my PhD at Hopkins, and we bought our first freestanding house, a cute little house with a big wraparound porch with flower boxes dotted all on the porch. And we bought this house in October, which is not the time to plant in Baltimore, so we didn't plant in the fall. But when spring came, my husband, who loves to garden, ran out with our marigold seeds, going to decorate our cute little house. But then he ran right back in because he said, Camara, some of these boxes have dirt in them, but some of the boxes are empty. I need to go down to the gardening store. So he goes down to the gardening store and he hauls back big old bags of potting soil, and then we fill up the empty boxes. Then we take equal numbers of our marigold seeds and put them in the different boxes, and we water them all equally. And then, because I'm not the gardener in the family, I was exhausted. So, I sat back just to be delighted. 3 weeks later, as I'm walking out of my front door, I finally pay attention to these flower boxes, and what I saw made me literally stop in my tracks. Because as I looked at those boxes, it looked to me like we had planted completely different species in some boxes versus others. Some of the boxes were full of plants, and they were tall and vigorous looking, and some of the boxes just had a few plants in them, and they were scrawny and scraggly looking. And then I realized what had happened. That potting soil that my husband had bought turned out to be rich, fertile soil, so that every single seed planted in the rich, fertile soil had sprouted. The strong seed had grown very tall and vigorous, but even the weak seed had made it halfway up. But that old soil that we found there turned out to be poor rocky soil, so the weak seed planted in the poor rocky soil just died. And even the strong seed in the poor rocky soil had to struggle to make it to a middling height. And some of you guys are nodding, so maybe there's some farmers or gardeners in the room, and maybe you've composted half of your garden, so maybe you've seen this image with your own real eyes. And the image, of course, is about the importance of the soil, the importance of the environment. But now I'm going to take this image, and I'm going to make it a story about racism by introducing a gardener. So now we're going to have a gardener who has 2 flower boxes. I'm going to come from behind here. I don't know if the sound is going to be as good, so turn me up on the thing, because I just want to get out here. So is the sound better back there? It's okay here? It sounds really funny to me here. But anyway, okay, it's good. So now we have a gardener who has 2 flower boxes, one which she knows to have rich, fertile soil, one which she knows to have poor, rocky soil. She has seed for the same kind of flowers, except some of the seed produces pink blossoms, and some of the seed produces red blossoms. And the gardener prefers red over pink. So what does she do? She takes the red seed and she puts it in the rich, fertile soil, pink seed in the poor, rocky soil. 3 weeks later, she sees in her boxes what I saw in mine. In that rich, fertile soil, all the red seed is sprouted, strong red seed, tall and vigorous. Weak red seed makes it halfway up. In the poor, rocky soil, the weak pink seed dies. Here comes the strong pink seed struggling to make it to a middling height. And then in those flower boxes, those flowers go to seed. And the next year, the same thing happens. And then those flowers go to seed. And year after year after year after year, same thing happens until finally, about 10 years later, the gardener's looking at her flower boxes and she says, I was right to prefer red over pink. So we're going to interrupt the story there to say the first part of this story is how institutionalized racism works, where you had the initial historical injustice of the separation of the seed into the 2 types of soil. You had the contemporary structural factors of the flower boxes, keeping the soil separate, and then through inaction in the face of need, perpetuation of the inequity. But let's pick this story back up to say, well, where would personally mediated racism be in the garden? Well, gardener's looking at the red flowers saying, I love those red flowers. They're so beautiful. Then she looks at the pink flowers and she says, oh, those pink flowers sure are scrawny and scraggly, so she plucks off the blossoms before they can even go to seed. Or maybe she notices that a pink seed has blown into the rich, fertile soil, so she plucks it out before it can establish itself, which is some of the anti-affirmative action stuff that goes on. And where would internalized racism be in the garden? Well, the red flowers are just living their lives, enjoying being red, many of them not acknowledging or maybe even understanding that they're benefiting from enriched soil. Pink flowers are looking over at red, thinking red is mighty fine and wishing with all their hearts that they too could be red. And here come the bees, minding their own business but collecting nectar at the same time. So here comes a bee into one of the pink flowers, and then to another pink flower, and to this pink flower, and this flower's like, get away from me, bee. Don't bring me any of that pink pollen. I prefer the red. because the pink flower has internalized that red is better than pink. So now the question arises, what do we do to set things right in this garden? Well, we could start by addressing the internalized racism, so we can go over to the pink flowers and we can say, pink is beautiful, power to the pink. And that is an important intervention. It is. I'm not making light of that. But if that's all we do, it's not going to change the situation in which those pink flowers find themselves. Or you might say, okay, well, let's address the personally mediated racism. Let's have a conversation with the gardener. Or better yet, let's have a workplace multicultural workshop for the gardener. It's all good, right? So we have our workshop, and in the workshop we say, dear gardener, would you please stop plucking those pink flowers? And maybe she will, and maybe she won't. But even if she does, it's still not going to change the situation in which those pink flowers find themselves. If we really want to set things right in the garden, we must address the institutionalized racism, which means we have to either break down the boxes and mix up the soil, or if you want to keep separate boxes, that's all right too, although it makes it easier for the gardener to continue segregating resources going forward. But if you keep separate boxes, it means you need to enrich that poor rocky soil until it is as rich as the rich fertile soil, right? I didn't say give the boxes equal amounts of soil. I'm talking about the difference between equality and equity there. You need to enrich that poor rocky soil until it is as rich as the rich fertile soil. And when you do that, the pink flowers will flourish. They'll be looking beautiful, grand, and glorious, so that in that intervention, you will have also addressed the internalized racism. Pink won't be looking over at red, thinking red is better, and wanting to be red. And in that intervention, you may also address the personally mediated racism. Now, the original gardener may have to go to her grave preferring red over pink, but her children who grow up and see the flowers equally beautiful will be less likely to have that kind of attitude. So the story has been to illustrate those three levels and to very strongly suggest that if we want to set things right in the garden, we have to at least address the institutionalized. Good to address all the levels at the same time, but at least address the institutionalized, and when we do that, the other levels may take care of themselves. So I can't look over here because I'm sure there's a time's up sign. So I just want to say... So I just want to, and I'm going to come back over here. I just want to say one more thing about the gardener's tale, and then if you will indulge me, I had one more story I wanted to tell. So talk to me about time. Just go. Okay. Wait, well, you can't say just go. Okay. Okay, then we'll hear it. Here's an important question that we haven't raised yet. Who is the gardener? After all, the gardener is the one that I gave the power to decide, the power to act, control of resources, which are actually the elements of self-determination, right? So who is the gardener? Well, government is a huge part of the gardener, as are foundations, corporations, communities to the extent that they have self-determination. But whoever the gardener is, it is dangerous when the gardener is allied with one group. I painted her red. That's why she prefers red over pink. And it's also dangerous when she's not concerned with equity, when she can look at her flower boxes and think that her garden is beautiful, thank you, because she's not even counting the pink flowers as part of her garden. And so the question arises, what do we do about the gardener? Do we make the gardener striped, polka dotted, or fuchsia? Do the pink flowers have to grow or recruit their own gardener? Lots of questions that can come out of this. I want to just share two questions that have come up in the past, and then over lunch or something we can have other questions. But one question that I was once asked is, excuse me, Dr. Jones, why should the red flowers share their soil? I loved that question when I heard it. Why? Because it showed me the power of this story to start conversations about racism that would otherwise be difficult if we were talking about racism between you and me. My answer to that question, why should the red flowers share their soil, is that actually that soil does not belong to the red flowers. It belongs to the whole garden. So we can have a whole conversation about that. And I was referring to that before. Here's another question. What if that's not the original gardener we're looking at? What if that's the gardener's great-great-great-great-grandchild? Here we are. And that great-great-great-great-grandchild has always seen the flowers looking like that, may not even think that there's a problem to be solved. So very quickly, first of all, we need to make the differences in the height and vigor of the pink and red flowers a problem requiring urgent solution. But that's not enough. We then have to make the flower boxes transparent to be acknowledging and addressing the differences in the quality of the soil. And as we make the flower boxes transparent, the third thing is that we have to make it absolutely clear that everybody understands that the pink seed did not just go launch themselves into that poor rocky soil. So we have to talk about history, and we have to talk about how the gardener's initial preference for red over pink set up the whole situation. That initial preference for red over pink is cultural racism, white supremacist ideology in our setting. We must address that, because if we don't, even if we were to compel that gardener to make the poor rocky soil as rich as the rich, fertile soil today, if she continues to prefer red over pink, she will continue to privilege red over pink going forward. So when I talk about, my analysis of racism used to just be about the quality of the soil. But I understand now that racism is a system that does two things, that structures opportunity and assigns value, and we must address both aspects if we're going to set things right in the garden. So very quickly, I'm going to just fly through some slides to get to the last story. Okay, you won't get the fullness of it. But how is racism operating here is a question I think we should take to our communities, to our workplaces. How is racism operating here in my child's school or whatever? And it's a legitimate question because racism is not a miasma. It is a system with identifiable and addressable mechanisms in our structures, policies, practices, norms, and values, which are the elements of decision-making. As I said before, structures are the who, what, when, and where of decision-making, especially who's at the table and who's not, and what's on the agenda and what's not. And whenever you sit at a decision-making table or set one, you should, I'm charging you now to do this. Look around and say, who is not at this table, who has an interest in this proceeding? And then your job is not just to represent their interests, your job is to bring them to the table. And if structures are the who, what, when, and where of decision-making, policies are the written how of decision-making, practices and norms are the unwritten how of decision-making, and values are the why. And I just had done a thought experiment about police killings of unarmed black and brown men and women, looking at it. So just quickly, structures, if you were trying to identify levers on which you could act, structures would be the presence or absence of citizen review boards. Policies, the use of the grand jury system to indict police officers. Not that this police officer shot a gun and that person's dead, but you have to go through this other process. That might be a lever we wanted to address. The over-policing of communities of color, causing more accidental interaction, is something that we might want to address. The blue code of silence, if a police officer sees something that another one does and doesn't say anything, that might be something we want to address. Or the values, the view of black men as inherently threatening, might be something we want to address. So this is just with a simple thought experiment of asking that question, how you can find at least 5 different areas of leverage. So, we talk about leverage, the Archimedes method or whatever. Anyway, so what is health equity? Very quickly again, 3-part definition. What is it? How do we get there? How is it related to health disparities? Health equity is a process. It's not an outcome. It's a process, assurance of the conditions for optimal health for all people. Achieving health equity requires at least these 3 things: valuing all individuals and populations equally, recognizing and rectifying historical injustices, and providing resources not equally but according to need. How is it related to health disparities? Health disparities will be eliminated when health equity is achieved. Health disparities are the differences in outcomes, counting the different numbers of different colored bodies at the bottom of the cliff, or counting the differences in the height and vigor of the pink and red flowers. Equities, all the stuff that came before. I had some ideas about operationalizing health equity. You can read them later because you can get these slides. You guys will have them, right? I said this thing about before, understanding that there's a difference between health disparities and health equities. We need to invest in opportunities, measure our impacts on the opportunities, and then patiently await the impacts on outcomes in a generation. If we enrich the poor rocky soil today until it's as rich as the rich fertile soil, that pink flower that's already in it might grow up another 1/4 inch, but we won't see the full impact until the seed that falls into the rich fertile soil rises up in the next generation. There are 3 barriers to achieving health equity. I'm glad I talked about them before. This first is this narrow focus on the individual, which makes systems and structures invisible or irrelevant. The second is that we're ahistorical and we act as if the present were disconnected from the past and as if the current distribution of advantage and disadvantage were a happenstance. And the third is this myth of meritocracy. Now, when we deny an uneven playing field, like if we deny racism, you're complicit with that thing. How can you deny racism? At least 2 ways. You can say one thing, I don't think racism exists, or you could never say the word racism in the context of widespread denial. Because if you never say that word in the context of widespread denial of racism, you're complicit with that denial. So here's what can we do in pictures. So we need to look for evidence of 2-sided signs. We need to shine the bright light of inquiry everywhere, right? We need to burst through our bubbles to experience our common humanity. In different parts of the bridge or different parts of the city. We need to be interested, believe, and join in the stories of others. We need to see the absence of, and we need to reveal inaction in the face of need, which is how institutionalized racism most often operates these days. I wanted to tell you about the International Convention on the Elimination of All Forms of Racial Discrimination, which is an international anti-racism treaty. I usually ask you questions, but we can't. the U.S. did sign this treaty way back in 1966, and we actually did ratify it 28 years later. We have international treaty obligations to do right under the treaty, including submitting periodic reports. And so we did that about every 6 years. A report is due. And then the committee to whom we submit the reports sends back their concluding observations, which starts out, "Dear United States, thank you for your report. We remain concerned about racial profiling, residential segregation, the achievement gap in education, differential access to health care, disproportionate incarceration, and on and on and on." And not only do they remain concerned, they have specific recommendations that we are treaty bound to honor, right? Some of the recommendations include raising public awareness of the existence of the treaty, so I try to do that every time I talk. I'm doing my part. And another one is recommending that we have a national action plan to combat structural racial discrimination. That's actually in our guidance that we are treaty bound to address. When I was president of the American Public Health Association, which you didn't hear in my intro, but when I was, I launched our association on a national campaign against racism with 3 tasks: to name racism, ask how is racism operating here, and then organize and strategize to act. And so here's the story. Did you get any of that? Okay, so here's the last story. Okay, and then I'm done. This story actually is not based on something I saw in my own real life. It's based on an image from the book, Why Are All the Black Kids Sitting Together in the Cafeteria and Other Conversations About Race by Dr. Beverly Daniel Tatum. In her book, she characterizes racism for most people as an entirely passive thing, right? People are just living their lives, going to work, raising their kids, whatever, but they're on a conveyor belt, on a people mover. So they're doing their regular things, but they're moving inexorably through racism and toward racism. I am going to take her image and expand on that image to talk about how we can become actively anti-racist. So I'm going to put us on this conveyor belt. Here we are. And we're just going to work, going to school, active in our communities, doing our stuff, and we're moving through racism. And actually the system, it's mostly white people up on top of the system, and the people of color are making the system run or whatever. We don't have to go that deep. But anyway, so here we are on this conveyor belt, and there's even a big sign up there blaring racism, 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 but we're so involved in our lives that we don't even see that sign. And maybe we do look up and we see the sign and we go, "Oh, racism," and then we close our eyes. So maybe we're in denial and we stay on it. Or maybe we might look up and say, "Racism," and then we turn around, but we don't do anything else. So maybe we're colorblind, right? But we're still on this system. What do I suggest we do? Well, hopefully, first of all, I'm hoping that some of you guys see the sign now. Okay, so here we are on the conveyor belt, and I hope that my stories and all have helped to say, "Oh, racism." Well, what do we need to do? We do need to turn around, right? But then we also need to take a step, right? And another step, and we have to become actively anti-racist. We need to start walking backward on this conveyor belt, and we need to walk at least as fast as the conveyor belt is going just to stay in the same place. So now let me ask you this. What happens when you're walking backwards on a crowded conveyor belt? You start bumping into people, and it becomes uncomfortable for them and uncomfortable for you, and they're like, "Hey, buddy, watch out. What are you doing?" Which is your opportunity to do the first of 3 stages of being actively anti-racist, which is to name racism, to say, "Do you see where we're going? Do you want to go there, or will you just turn around with me?" Now, most people do not want to be disturbed out of their comfort. So they're just like, "Well, just leave me alone." But maybe 1 or 2 will turn. So now you have 2 or 3 of you walking backwards on this crowded conveyor belt, and you keep bumping into people, and you keep naming racism and inviting people to turn, and more will join you. Never 50%. Don't even hold out for 50%. But now you're developing a critical mass, right? And as you develop this critical mass, now you can not only just stay in the same place, but you can start moving not only away from the sign, but where are you trying to get? You're trying to get to the motor that is running this system. So now we're here at the motor, and now it's the time for the second stage of being actively anti-racist, which is to ask the question, how is racism operating here? Looking at structures, policies, practices, norms, and values. So I think it's this lever. So I'm going to reach down and the whole system starts shaking, and I did it. Except racism is a very fancy system, and it reconfigures itself, and it keeps on going. Which talks about the importance of the third stage of being actively anti-racist, which is to organize and strategize to act. So as I'm pulling on this pulley, I need you to push a button. I need you to pull on, as I'm lifting the lever, pull on the pulley. Somebody needs to swing a pendulum. Each of us needs to take a piece of this machine. And I really believe that all of us working together can dismantle this system and put in its place a system in which all people can know and develop to their full potentials. That is our challenge, especially now, and I invite you, especially, we can do better. Yes, we can. Thank you very much. And we can. Thank you.